Hi everyone! Today our group will talk about cognitive therapy. Aaron Temkin Beck was the proponent of cognitive therapy. He was born on July 18, 1921. He was the youngest of 5 children. He theorized that in order to change the symptoms, one must change their distorted thinking. This belief led to the development of the cognitive behavioral therapy. That is why it is also called Beckian therapy. Cognitive therapy is a type of cognitive behavioral therapy and it is the most popular version of CBT. It is based on the idea that we can change our thoughts and behavior and it will result in changes in what we feel. So basically, cognitive therapy it tackles about the relationship of thoughts, feelings, and behavior and how that relationship can be modified to alleviate the negative thinking or thoughts. One of the major assumptions of cognitive therapy is that the way people think about things influences how they feel emotionally and what they do behaviorally. When people are in psychological distress, their thinking is not accurate, not realistic, and not helpful. People can learn to identify, evaluate, and change their assumptions and core beliefs just as they are able to identify and change their negative automatic thoughts. So one of the important part of cognitive therapy is to help people identify their thinking that is leading them to feel distress and to act ways that is not very helpful to them, and then learn how to evaluate this thinking to see how realistic it is. So now let's proceed to the key constructs. First one is core belief. It is a central belief that people hold about self, others, and the world. It is usually negative and it is formed through childhood experiences. One example of this is the world is dangerous or the world is not safe. Intermediate belief are attitude, rules, and expectations. If the core belief is inaccurate, then the intermediate belief can be affected and it can be inaccurate too. One example of this is that if I am thin, then I will be loved by others. Automatic thought, on the other hand, is the images or mental activity that occur as a response to a certain trigger. One example of this is always thinking that the worst is going to happen. And we also have cognitive distortion. It is the consistent errors in thinking. It is the exaggerated and irrational thoughts. For example, patient A just failed the math subject. He thought that he is not good in school, so he might drop all of his subjects. Next is the cognitive distortion. It is the consistent errors in thinking. It is the exaggerated and irrational belief. For example, patient A just failed the math exam. He thought that he is not good in school, so he might drop all of his subjects. And lastly, schema. It is the belief in oneself and the environment. Sometimes schema can be positive and sometimes it can be negative. One example of dysfunctional schema is no esteem. So one believes that he is not lovable and he is rejected by other people.
Hello, so here I am to discuss further what is cognitive distortion. So cognitive distortion is a way of our mind to perceive things differently or negatively. These negative thoughts are actually the ones that are used to reinforce negative thoughts in our minds. One common cognitive distortion is filtering. It is when you set aside all the positive aspects and focus on the negative ones. For example, you have received test results from the midterms and all you had were A, but in one of your minor subjects you had a B. You chose to focus on the B alone and disregarded the positive A's that you got, saying that you could have done better, but you disregarded the fact that you did well actually receiving all A's in other subjects. Another one is the polarized thinking, or also what we know as the black and white thinking, or some other people call it as the all or nothing. It is when the person chooses what's going to be the outcome. Is it all or nothing? They don't actually try to see the gray areas or other possibilities other than the all or the nothing. Another is the overgeneralization. It is when you overgeneralize things and thinking, going into further depth with the possibilities. For example, a student receives a single F on one of his quizzes, therefore concludes that he is a no-brainer and that he should stop school. Another is catastrophizing. This is when you think of all the worst possible situations that could happen in a situation. For example, someone is late to a party and you instantly think they got into a car crash or they went to jail or other possibilities that would be catastrophic, which is not actually true. Personalization is when a person thinks that everything is directed towards them. All the actions, all the reactions, and all the feelings are directed towards them. For example, you went to a party late and everybody didn't have a great time. You directed it towards yourself, saying that I could have been earlier, I could have made other preparations that would have probably been better, and you would actually sometimes say that you were the sole reason why the party was boring. But in conclusion, you actually are just thinking about negative thoughts and the party's fault wasn't actually in your doing. Control fallacy is when two conclusions are related to each other but aren't actually the cause. For example, you pass your work late or your work is incompetent because you think that your boss is putting hard work on you, demanding a lot of stuff, but in reality, you are just actually thinking negatively about the things that you have experienced. Fallacy of fairness is when you apply the ruling of fairness to a certain situation. For example, you saying that life isn't fair, so therefore I am not in a position where I should try better because negatively speaking, life isn't fair. So you think that if you exert effort, nothing's going to happen to you because life isn't fair. Blaming is when we tell other people that they have the credit of us being miserable in life. For example, don't blame stuff on me because I am this, I am that. You have to pity me, and sometimes you would blame other people about our instances in life that actually was a result of our own decisions and not theirs. Shoulds is when we take a lot of pressure towards ourselves. For example, I should work out daily, I shouldn't be lazy, or else I would be fat. That is one of the most common cognitive distortions out there, putting pressure towards ourselves, thinking negatively because of the shoulds, the woulds, and the I could'ves. These are the 10 common cognitive distortions, and please refer to the last 4 below for the other descriptions. There is also what we call the Beck's cognitive triad. It is the 3 key elements of life in depression. It is the negative triad, also known as. It is when we view the world negatively, therefore making us believe that the future will also be a negative aspect, influencing a negative view on ourselves. This cognitive triad leads to cognitive distortions, which manipulates our mind into thinking negatively, and other cognitive distortions in our life.
So now let's move on to the focus and goals of the cognitive therapy or Beckian therapy. So first, cognitive therapy focuses on how a person thinks, communicates, and behaves today rather than his or her early childhood experiences. So compared doon sa psychoanalytic therapy ni Freud na nagfo-focus 'di ba sa childhood experiences and everything, dito sa cognitive therapy ang focus today. So, using cognitive therapy, the therapist helps the client to identify the specific cognitive distortions using cognitive assessment and provide guidance on how to change these thinkings. So, next is that cognitive therapy focuses on how a person's thoughts leads to feeling of distress. So, ang idea kasi behind cognitive therapy is that how you think determines how you act and feel. So, cognitive therapists helps the client to relieve their stress by changing the dysfunctional thoughts they have and seeing or looking how they misinterpret some situations in their lives. So last, cognitive therapy aims to change the thoughts and associated behavior underlying the disorders rather than just relieving the symptoms associated with them. So, ang aim kasi ng cognitive therapy ay bukod sa malaman ay baguhin kung yung thought o yung pinaka-ugat kung bakit ganon mag-isip at mag-behave yung tao rather than just yung mga simptomas lang na nararamdaman niya or kung paano lang siya mag-behave. So, let's move on to the goals of the cognitive therapy. So, first, its goal is to change the cognitive distortions that an individual is experiencing or having using cognitive restructuring or by examining the rationality and validity of the assumptions behind them. So next is cognitive therapy helps in reducing relapse rates in depression and schizophrenia. So most especially sa mga pasyente na nagre-respond lang marginally sa mga antidepressant medication. So with the help of cognitive therapy, nababawasan yung chance na mag-occur ulit or maranasan ulit ng pasyente yung depression and schizophrenia. Also, cognitive therapy is being frequently prescribed as an adjunct or complementary therapy sa mga pasyente na may back pain, cancer, rheumatoid arthritis, and other chronic pain diseases. Also, cognitive therapy can be useful to those patients na may anger management problems, and also, cognitive therapy is reported to be effective in treating insomnia. Also, cognitive therapy helps in treating number of mental disorders that are written in this slide. As you can see, there is agoraphobia, Alzheimer's disease, anxiety or panic disorder, ADHD, eating disorders, mood disorders, OCD, PD, PTSD, psychotic disorder, social phobia, and substance abuse disorders. So, even though proven and tested na effective ang cognitive therapy sa maraming mental disorders, there are still instances and situations na hindi angkop at ginagamit ang cognitive therapy, such as to those individuals who have significant cognitive impairments such as traumatic brain injury and organic brain diseases. Also, cognitive therapy is not applicable to those applicants who are not willing to take an active role in the treatment process. Hindi sila good candidate for this such therapy, no? So, aside from limitations, cognitive therapy also has its weaknesses. So, first is that this model appears to confuse the symptoms of depression with its cognitive causes. So, examples ng sintomas ng depression ay negative self-concepts, self-criticisms, all-or-nothing thinking, exaggerations of negative experiences. So, in this therapy, it mapapatanong ka kung yung mga sintomas ba na to ay cognitive causes or sintomas talaga siya ng depression. So, yun lang yung medyo tricky sa using this such therapy. So, next is that it uses such terminology as negative self-concepts, irrational beliefs about the self, dysfunctional self-concept, and biased cognitions about the self as if they are synonymous or interchangeable. So, for example, a patient has sexual and physical abuse experiences, and this have left him or her an enormous scars in her life. So, in such circumstances, cognitive restructuring exercises na may emphasis in reframing reality and not on changing it do not really solve or deal with the true problem na kinahaharap ng pasyente. So, next is that research has shown that positive self-evaluations may be dysfunctional and maladaptive. So, isa kasi sa techniques ng cognitive therapy, which will be discussed later, is self-evaluation, which is sinasabi ng iba na may pagkabias and inaccuracy, especially in the fields of health, education, and workplace. Kasi nga, sinasabi nila na puro positive lang. What about the negative self-thoughts that a person has? So, last but not the least is that this therapy puts a strong emphasis on examining the association between negative thoughts and mental dysfunctions, but it does not answer the question of why individuals choose to focus on their negative attributes when the positive evaluation of the self is more accurate. So, neither this therapy has two findings, which is the self-blame bias and self-serving bias. Also, research has shown that people have the motivation to see the self positively and avoid a negative self-concept exhibiting self-serving bias. So this includes blaming their failures on situations while taking credit when they succeed.
So, dumako naman tayo ngayon sa techniques. So, yung unang-unang i-discuss ko na techniques is validity testing. From the word valid, dapat totoo, dapat may supporting evidence, dapat basta factual, di ba? Dapat accurate, ganon. So, sa therapy na to, inaalaw ng therapist yung client na i-defend yung beliefs niya or yung thoughts niya na may kasamang objective evidence. So, kapag hindi na-defend ng client mo yung paniniwala niya yon, yung irrational thoughts niya yon, yung irrational beliefs niya na yon, doon na-expose yung faulty nature or invalidity ng belief niya na yon. Kung saan yun yung goal ng therapy na to. So, yung susunod nating technique is what you call cognitive rehearsal. From the word rehearsal, ibig sabihin pinapractice or repeatedly na ginagawa. So, dito, i-allow mo yung patients mo, yung client mo na mag-imagine ng difficult situation or scenario from the past na encounter niya, at kapag successfully niya yung nagawa, together yung client at yung therapist, they will practice how to cope up with that or how to overcome that difficult scenario or situation, para in that way, kapag na-encounter ulit yun ng client, yung pinractice nila, yun yung gagawing behavior ng client. So, yung susunod na technique sa pag-uusapan natin ay tinatawag na journaling. So, yung journaling, ito yung parang detailed diary na nangyayari sa mga araw mo, ganun, kung anong naramdaman mo, kung ano yung emotions mo, kung ano yung thoughts mo noong araw na yon. So, everyday siya ginagawa. Etong journal na to, natutulungan niya yung therapist ma-identify yung mga maladaptive behavior patterns at kung ano yung nagiging impact nito sa behavior natin. So, pwede mo i-list dito yung mga negative thoughts mo, yung mga positive thoughts mo na nangyari or nag-occur sa'yo nung araw na yon, at saka dito ma-realize mo or makikita ng client kung gaano nakalayo yung narating niya or yung process niya dun sa therapy. So, yung susunod nating techniques is what you call homework. It is actually a set of assignment given by the therapist to the client. So, this assignment actually may include take down notes during the session, or review of audio tapes, or reading new journal articles or magazine na related sa topic nila. So, dito, parang tinutulungan ng therapist magkaroon ng self-discovery at may reinforce yung insights ng client through doing his or her homework. So, yung susunod ay yung guided discovery. So, ito, meron siyang set of questions na ginaguide yung client para ma-discover niya yung sarili niyang cognitive distortions. So, dito, challenge ng therapist yung pananaw ng client or yung beliefs niya, and then pinapalawak din, at the same time pinapalawak din ito yung pananaw ng kanyang client. So, sa pagsagot, pwede kang i-ask ng client, ng therapist mo kung ano yung ebidensya na makakapag-support dun sa sagot mo at yung mga ebidensyang hindi makakapag-support dun sa sagot mo. Nagets niya? Ebidensya makakapag-support at ebidensyang hindi makakapag-support. In that way, yung client natutulungan siya na tignan yung iba't ibang perspektibo na hindi niya kinonsider nung umpisa pa lang or bago pa lang i-apply yung technique. So, ang huli nating pag-uusapan na technique is what you call modeling. So, ang modeling, it is a role-playing exercises na ginagawa ng therapist na kung saan nag-a-act out sila ng mga different behaviors na appropriate dun sa situation na kinakaharap nila. This actually allow the client to explore behaviors na pwede niyang gawin in case na ma-confront siya ng situation na yon. This therapy is actually helpful kasi binabawasan nito yung fear, yung anxiety kapag harap mo yung situation na yon. And then, ini-improve nito yung mga skills natin like problem-solving skills, gaining familiarity and confidence, practicing social skills, assertiveness training, at saka ini-improve din nito yung communication skills natin.
Other distinctive features and techniques of cognitive therapy. First is collaborative empiricism. This term is used to describe the working style of therapy, where therapist and client join forces to tackle the latter's problem. By collaborating, clients are actively engaged in the problem-solving process. This can build relationship like warmth, trust, genuineness, and empathy. Second is openness. As cognitive therapy practice is based on collaboration, therapy is open and explicit about what is going on. So the city model is explained to the client and their permission is sought to apply it to their problems. The case conceptualization is shared with them. Therapist mistakes are admitted and clients are encouraged to come up with a solution when therapy becomes stalled. Itong therapy na to is nakakatulong para maging komportable rin yung therapist and the client so that they can freely express themselves. Third is agenda setting. This is a business-like approach to therapy, but it is not carried out in an impersonal way. Client and therapist agree in each session which topics to be put on the agenda. And this device keeps both participants on track, thereby preventing or minimizing drift. Agenda setting militates against the client playing a passive role in therapy and makes efficient use of therapy time. The usual items placed on the agenda are undertaking mood check, including review of the client's inventory scores such as those of the Beck Depression inventory, eliciting feedback from the previous sessions, reviewing homework, agreeing on topics for the current session, negotiating new homework, and asking for feedbacks about the session. Nakakatulong din to para maging mas maayos yung flow ng therapy and mas maging aware ang therapist sa mga issues and mas matackle na maayos yung mga concerns ng client. Fourth is problem, focus, and goal orientation. Clients are encouraged to list their problems in the first session and establish a goal for each one. Problems are prioritized, though the most troubling ones may not always be tackled first. This teaches clients that an early problem-solving focus is sought after rather than they using up valuable therapy time with rambling or long accounts of their current difficulties. Goals are stated in clear and specific terms so that progress towards them can be measured rather than assumed. If clients are ambivalent about the change, then it is too early to introduce a specific goal, and discussion should focus on the client's concern about change. It is important that goals are within the client's ability to achieve. Setting goals foster hope in the clients that change is possible. Goals can change over the course of the therapy as information is obtained, problems change, or new ones emerge. Sa session na ito is tinutulungan ng therapist ang client na ma-achieve ang mga goals niya sa pamamagitan ng pag-resolve muna ng mga problema niya. Inuuna nila yung mga easy to achieve goals para one step at a time and take it easy lang yung maging flow ng session. And also, nakakatulong rin to sa mga na mag-set ang client ng mga bigger goals and magbigay din ng hope na they can achieve that. Fifth is here and now focus. As discussed in theory section, CT largely focuses on finding specific solution to current problems. Exploration of the past only occurs when the patients express a strong predilection to do so. So when work directed toward current problems produces little or no cognitive, behavioral, and emotional change, or when the therapist judges that it is important to understand how and when important dysfunctional ideas originated and how these ideas affects the patient today. However, continually looking backwards can convince the client that the solution to her problems lies in understanding her past instead of changing present circumstances so that tomorrow can be better than today. Sixth is feedback. Feedback is obtained during the session and at the end of it. There are two types of feedback. First is in-session feedbacks. It enables the therapist to ascertain if the points she has been making are understood by the clients and correct any misunderstanding that may have arisen. It is just like asking if there is something that the client didn't understand or there are unclear informations during the session. The second is the end of session feedback. It asks the client to cast his eye over the session. For example, is asking the client what was helpful and unhelpful about today's session. It is important for the therapist to react non-defensively to client's criticism of her or therapy. If she does react negatively to such criticism, this may indicate to clients that only positive feedback is really wanted. Feedback is important part of openness and collaboration of CT and communicates to client that their views are taken seriously by the therapist. Seventh is becoming a self-therapist. The ultimate aim of CT is for the clients to become their own therapist by using the cognitive model for present and future problem solving. As the client's problem solving abilities increase, the therapist can become less active in guiding therapy and transfer more of the responsibility for directing it to her client. The transition from client to self-therapist can be matched by the therapist transition from therapist to consultant or coach. Independence and self-reliance are explicit client goals in CT. The client will become independent and can understand more about her problems and goals, and becoming self-reliant on identifying and exploring her thoughts and feelings. Last is dealing with relapse. Instilling hope in clients that they can change is an important part of the therapy. Addressing the likelihood of relapse is perhaps equally as important. Because the likelihood, it is the wiser to use the term like relapse management instead of usual relapse prevention. Clients can be taught that setbacks are likely to occur at some stage of the attempts to maintain change, but these setbacks are only incidents and not the whole story of their progress. Additionally, setbacks can be seen as valuable learning opportunities, not sign of personal failure, which is constructively handled will put clients back on track. In closing session of therapy, clients summarize what valuable lessons they have learned in CT. Possible future difficulties that may trigger a relapse are pinpointed and coping strategies are rehearsed to deal with them. Booster sessions can be arranged to monitor clients' progress and focus on any problems they are finding hard to deal with. To reduce the chances of relapse, clients need to practice their CT skill as a way of life. And that's all about the cognitive therapy. Thank you.